Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, for the talk today.
Thanks, Kent. Thanks, everybody, for coming. Goal today is to review a couple of what I thought were high-yield studies from ID Week. ID Week, formerly called IDSA, was a really good conference. I know a couple of you were there. It was great to see the couple of you who I was able to see. There was a lot of general ID discussions. There was a lot of really interesting stories from Ebola survivors and things of that nature. There were also a couple of what I thought were soon-to-be very pertinent ARV-related studies. So I'm just going to cover two of those. The two that I'm going to talk about are, number one, a study of switching from a single tablet regimen that includes TDF to a single tablet regimen that includes TAF. And then what I thought was kind of the most surprising ARV study of the conference, a study for treatment-experienced, very complicated individuals simplifying salvage therapy to a single tablet ECF-TAF plus darunavir. So this is going to be a lot of alphabet soup here. I've listed some of the abbreviations. It was just too hard to write them all out. So there you'll have a list of all the abbreviations there, and I'll try to use several different names for these drugs when I talk about them. But let's start with just what's the big deal about TAF? So this is something a lot of people are excited about. We've been talking a lot about here. This is a slide, thank you to David Spock for sharing with me, and I just modified slightly. But let's start with what is the difference between TDF and TAF. So in all of our current regimens in which we're giving so-called tenofovir, is what we usually call it. What we're actually giving is this TDF, or tenofovir disoproxil fumarate. So what happens here is our pill of TDF, this is in Truvada, in our other single tablet tenofovir-containing regimens right now. TDF itself in the plasma becomes hydrolyzed and becomes tenofovir, or TFV. And this is the molecule that gets delivered to the lymphoid target cells, to the places where we want it. However, because there are very high levels of tenofovir, or TFV, in the plasma, it also gets delivered places we don't want it. The kidneys, the bones, and this is what leads to the renal toxicity, the bone toxicity, and things of that nature. So how does TAF differ? So here's TAF. The big difference is that TAF really doesn't get hydrolyzed or converted to TFV until it reaches the target lymphoid cells. So it's converted by this enzyme, cathepsin A, which primarily is only present in the lymphoid cells. What does this mean? It means much lower plasma levels of TFV, or tenofovir. It's been shown about 91% lower plasma levels, which means much less tenofovir to the kidneys, to the bones, to the places where we don't want it. There still is a little bit of conversion here to tenofovir, but much, much less, 91% lower. And this is probably what leads to lower rates of renal and bone toxicity. So this is why people are excited about TAF. This is why it's likely going to be beneficial. So the first abstract I'm going to share with you here, and both of these studies today are from Gilead. I have no financial disclosures or financial interest in Gilead, but I present these studies because I do think they're going to become highly clinically relevant very soon. So this study looks at switching from a single tablet with TDF, so ECF-TDF or Stribild, which is currently available, to a single tablet with ECF-TAF. So here's what they did. So this is a randomized open-label study. They enrolled HIV-infected adults with an HIV RNA less than 50 copies for at least 48 weeks on a TDF comparing regimen. They recruited these participants from 6 other Gilead studies. So all of these folks had been on a first regimen containing TDF and suppressed for at least 48 weeks. All had a GFR above 50. And you can see here the overall numbers. And this is impressive because this is the largest switch study to date. So we've talked about a lot of switch studies in the past. None of them have been nearly this large. So overall, over 1,400 participants. You can see 601 were on TDF-FTC or Truvada plus atazanavir boosted by either cobicistat or ritonavir. 376 on a tripla TDF-FTC of Favrins, and 459 on ECF-TDF, which is Stribild. They were randomized 2-to-1 to either switch to this new experimental ECF-TAF, so this is basically Stribild but replace the TDF with TAF, or to stay on their current TDF-based regimen. The overall baseline characteristics between these two arms were quite similar. The one criticism is that there were less than 10% women in both arms of this trial. So just like the Stribild studies, this study is being criticized for having very few women and As we've seen in other Gilead studies, they have simply had a difficult time recruiting HIV-infected women for these ARV studies. The primary endpoint was an HIV RNA or viral load less than 50 copies at 48 weeks, though they are following all these participants out to 96 weeks. Here is the overall data. These numbers we had seen from IAS in Vancouver, and then I'll show you in the next slides what was new here at ID Week. So you can see the blue bar is ECF-TAF, the new experimental, basically Stribild with TAF, compared to the green bars are the prior TDF comparing regimens. So in the arm that switched to ECF-TAF compared to the prior regimen, you can see comparing all prior regimens, those who got ECF-TAF did better. This is based on viral load at 48 weeks. Those who got ECF-TAF compared to a tripla did better. Those who got ECF-TAF compared to boosted atazanavir also did better. So we're seeing better virologic response here with this new single tablet regimen that includes TAF. Now here is what I'm going to focus on, and this is what we saw at ID Week. This arm where they compared ECF-TAF to those who stayed on ECF-TDF or Stribild. So the advantage of comparing these two arms is we're basically comparing TDF directly to TAF. That is the only medication different in those two regimens. And you can see here we have non-inferiority and really very similar virologic outcomes. There were equal numbers of virologic failures, both of which were very low. There were very similar rates of general side effects. Interestingly, there were more reports of depression and AST elevations with TDF, although that really hasn't been seen in other studies, so I doubt that's really clinically significant. But I think the most important thing here is this really allows us to compare effects on bones, kidneys, and lipids between TDF and TAF. So that's what I'm going to focus on here. So looking at these two arms, those who switched from a tenofovir-containing regimen to ECF-TAF, or those who stayed on basically what is Stribild, and what we'll look at first is effects on the kidneys. And what you can see here is markers of general proteinuria and then very specific markers for proximal tubular proteinuria in retinol binding protein and beta-2 microglobulin. What you can see here is that all of these markers for renal dysfunction favor the TAF arm. Those who switched to TAF, this was really impressive. Almost immediately, their kidney function improved. I don't have the graph with time points, but it was really impressive to me how quickly these markers of kidney function, within 2 weeks, they started to get better. Serum creatinine came down. It's not shown here, but fractional excretions of phosphate came down, and all of these other markers of both general proteinuria and tubular proteinuria started to improve even within 2 weeks with the switch from TDF to TAF. So you can see here the changes, all of which were highly statistically significant. When we look at bone mineral density, similarly, it favors the TAF arm. Those who switched from TDF to TAF very quickly had improvements in bone mineral density, and when they followed over 48 weeks, a much higher proportion had a normal bone mineral density. This was impressive to me, and this comment was made after the presentation that, remember, all of these individuals had already been on TDF for 48 weeks. Now we're following them for another 48 weeks. So this just shows that even in that second year, even beyond that first year of taking TDF, people's bone mineral density continues to decline. The switch from TDF off TAF, I don't think there's any magic to TAF, but I think it's just getting them off TDF leads to improvements in bone mineral density very rapidly. Now, the one thing that favors the TDF arm is lipids, and there was a lot of discussion about this after the session. So we know that TDF has some inherent lipid-lowering value. So you can see in those who stayed on ECF-TDF, lipids continued to, very small degree, but continued to improve, whereas those who switched to TAF, again, I don't think this is really a side effect of TF. I think it's just switching off TDF. Lipids actually increase. So you can see increases in LDL, although the point that presenters made is you also see increases in HDL, and overall the total cholesterol to HDL ratio didn't change that much. So is this clinically significant? I don't know. I felt like the presenter kind of downplayed this. I think this is one outstanding question, and it may be that those who switched to TAF, we're going to be doing a lot of switches, I think, in the near future. It may be that lipids worsen, and it is one factor to consider. When they looked at those participants who initiated a lipid-modifying agent, it was not overall that different, slightly higher in the TAF arm. Their conclusion here is that at 48 weeks, patients who switched from ECF-TDF or Stribild to the soon-to-be available, hopefully, ECF-TAF, remained on treatment, maintained high virologic control, had significant improvements in the hip and spine bone mineral density, serum creatinine, and significantly less general proteinuria and specific proximal tubular proteinuria compared to those who remained on ECF-TDF. They did say longer-term data are needed to understand the clinical relevance of the lipid changes in the TAF arm, and I agree. Let's change then to treating very highly treatment-experienced individuals with a lot of resistance. And I was surprised that this study was done. Stepping back, you'll recall there's been a lot of concern about Stribild or ECF-TDF plus darunavir. We've talked about this here on Echo. We've talked to folks from Gilead. The party line has really been to avoid that combination because of a very complicated interaction that leads to lower darunavir and elvitegravir levels. However, here's a study of ECF-TAF plus darunavir, and these were very difficult to treat individuals. I'll come back to why they did this and why they thought this would be okay. So they randomized 136 HIV-infected adults in an open-label fashion. All of these individuals were suppressed for at least 4 months on a darunavir-containing regimen. All of them had at least 2 prior episodes of virologic failure and at least 2 class drug resistance. Other criteria, they did not have any darunavir resistance-associated mutations. They did not have documented integrase inhibitor resistance, or they were on raltegravir and suppressed, so presumed to not have integrase resistance. They all had less than 3 thymidine-associated mutations, and they did not have either of these mutations that cause very broad class NRTI resistance. All had an EGFR above 50, and they were randomized 2-to-1 to either simplify their current salvage therapy to ECF-TAF plus darunavir, so this would be 2 pills once per day, or continue their current antiretroviral regimen. Here's just a little bit about the baseline characteristics. You can see overall they're very similar. There were a higher proportion of male participants in the ECF-TAF plus darunavir arm. There were more African Americans in the continued baseline regimen arm. And then here I just show this to show how difficult to treat these individuals are. These are folks who have been on extensive salvage therapy. The mean number of pills per day in their ART regimen were 5. Many had more pills than that. Many had BID dosing. Here's the proportion on tenofovir, which becomes relevant when we talk about kidney changes with the simplification. And you can see here all had at least 2-class resistance, and a significant proportion had 3-class resistance. And you can see here the proportion with various resistance-associated mutations. Now, the one thing I would say is that there's been a lot of concern about Stribild or ECF-TDF plus darunavir. As part of this study, they did a sub-study analysis looking at darunavir concentrations, darunavir and elvitegravir concentrations when ECF-TAF is combined with darunavir. And the bottom line, the punchline is they found it to be okay. They found the darunavir and elvitegravir concentrations to remain above the predicted inhibitory concentrations. And really, this is the first clinical data that we have to suggest that ECF-TAF plus darunavir is probably okay. It was a very small sub-study. I talked to the presenter about this afterwards, and still the party line is to avoid Stribild plus darunavir because we have no clinical data. But here is some suggestion that ECF-TAF plus darunavir is going to be okay. So I thought this was quite notable. Here are the final results, and you can see at their primary endpoint, which was week 24, viral load less than 50, there was no significant difference, maybe a trend towards ECF-TAF plus darunavir being better. When they looked at week 48, either viral load less than 50 copies or a more strict criteria of less than 20 copies, actually the simplification to this 2-pill regimen of ECF-TAF plus darunavir did better in terms of virologic outcomes. In terms of renal parameters, also similar to the prior abstract, those who simplified to ECF-TAF plus darunavir, the kidney function did better. Remember, about 60% of the baseline regimens included TDF. So their conclusion is that for treatment-experienced individuals with at least 2-class resistance on complex, high pill burden regimens, switching to this 2-pill once-a-day potent regimen of ECF-TAF plus darunavir provides a simple, once-daily 2-pill option with superior efficacy. So I think for very difficult to treat individuals on salvage therapy, this is going to be a very palatable option because it's just 2 pills once per day. Just to wrap up, I tried to look at when we can expect to hear from the FDA about various TAF regimens. Don't hold me to these dates, but this is the best I could find. So first, we will likely hear about ECF TAF with a target FDA action date early next month. There has been a new drug application submitted for TAF FTC rilpivirine, basically a complarapil with TAF instead of TDF. This is the most general that I could find. I couldn't find an exact date. And then 2 different doses of TAF and FTC with a target action date of April 7th. The one thing I should say, the other advantage of TAF is it's effective in very small doses, only 25 milligrams without a booster and 10 milligrams if a booster is involved in the regimen. That's why the 2 doses. And I couldn't find anything about this pill that combines TAF and darunavir, but I do understand it's being studied and is in development. So let me wrap up there and see if there's any questions about these 2 abstracts. I do think we're going to be talking a lot more about TAF in the very near future.